Hello, everyone. My name is Abhi. This is Nathan, Neil, and Shrija. And our project has to do with using machine learning to detect organ failure in car crash victims. So where does the problem arise? Basically what happens is currently when a car crash occurs, it takes between 7 to 15 minutes for an ambulance to arrive on the scene of the incident. After that, it takes about 8 minutes of transport, at which point the patient arrives at the hospital where diagnosis and treatment occurs. Now during this process, we may lose some patients because they're not diagnosed fast enough required for their treatment. So what the goal of our project is to figure out a way if we can do early diagnosis such that by the time they arrive at the hospital, their treatment can begin.
So our primary source of data for creating these models was the Mimic3 database, which is a compilation of data of ICU patients, over 58,000 of them. And so these patient data are from Beth Israel Deaconess Medical Center, which is located in Boston, Massachusetts. And this data contains a lot of pertinent clinical information about these patients, such as gender and ethnicity, which we use to improve our models.
So the three main features we emphasized on our model was the electrocardiogram, electroencephalogram, and the respiratory rate. And the reason we use these three types of waveform data in particular was because we believe that the heart, the brain, and the lungs were the three most vital organs, and therefore we wanted to be able to classify any injury to those organs or any combination of the three. So in order to begin our data extraction process, we started by creating a SQL query that compiled all the relevant motor vehicle patient data. And this included the DRG codes, which are the descriptions of the injuries, as well as the doctor notes and the admission diagnosis. And so our first original query consisted of 576 patients. However, this number was narrowed down to 67 due to the fact that only a fraction of the patients had available waveform data with it.
So in order to expand our sample size, we did more extensive SQL querying and more extensive keyword searching. So initially, we focused in on just searching for motor vehicles, but then we focused on maybe going for more specific motor vehicles such as cars, bicycles, buses, motorcycles, basically any type of motor vehicle we could think of. And as a result of that, we came up with 1,000 patients in our new query. And then after downsizing this to take into account the waveform data that was available for these patients, we had a final sample size of 142 patients. And with these patients, we manually classified them based on their area of injury. And these classifications basically fell under any of the 8 combinations of heart, brain, and lungs.
The MIG dataset was fundamental in the development of the neural networks. However, due to the nature of the environment where the data was collected, in this case, the hectic environment of an ICU, there were irregularities in the data, which make it difficult for an end-to-end deep learning approach. So in order to kind of reduce the variance in the waveform data, we utilized 2 different filters. The first one was a Butterworth filter in order to denoise the waveform data, and the second one was a Fourier transform in order to discretize the waveform data into frequencies in order to simplify the computations for the neural network. Another step that was taken was to make sure that the data for each patient was limited to a single development subset to make sure that there was no redundancy within the testing process. In order to verify our hypothesis that a deep learning approach could, in fact, both automatically extract features from waveform data and also automatically identify the specific organ trauma, we utilized a multitude of neural network architectures we tested, and the one that we did identify as the highest performance was the convolutional neural network, and which was much more efficient than the other ones we've tested with only 9 layers.
So here are some early results that we received from our project. So the CNN had a better F1 score, which is basically optimized for true positive rate of 0.82 as compared to the artificial neural network, which had a 0.56 F1 score. This suggests that the CNN will perform better in early detection of organ failure. But this is just the first results that we're getting. We're going to start investigating with more advanced machine learning models such as LSTMs and recurrent neural networks. So that way in the future this could be implemented to a similar device like Cardia, which would be with the patient to be able to detect it later in the future. At this point we're open to questions.
Wow, amazing. And they did it in 5 minutes flat, too. So how old are you guys?
Okay, so I'm 17 and I'm from Dallas, Texas.
I'm also 17 and I'm from Palo Alto, California.
15 from Pennsylvania.
I just turned 17 yesterday. I'm from Elkin City, Maryland.
And you're having such a good time at this meeting, right, to celebrate your birthday.
Yes, I am.
I am just inspired by all of you. I mean, when I read this abstract, I had no idea how old you were, but let's give them another round of applause. I think, I'm hoping at least 2, if not more of you, are going to go into biomedicine in some fashion. Are anyone thinking about medicine? At least one? Can we convince the 3 of you also? Randall, you had something. I'm sorry? Oh, how did they get together from different parts of the... I mean, the younger generation is so good about that, right? You just...
Sure, to a significant degree.
Yeah.
So we're actually working in collaboration with MIT through the program called MIT Beaverworks Midlytics.
Okay.
So we use data from a Lincoln Laboratory and a lab of computational physiology to create our project and use the data from it.
Randall, you need to hire them to consult with you. And
Going into medicine or not, but would you like jobs tomorrow?
Yes.
you may or may not remember about 4 or 5 years ago when we had our first gathering for AI medicine. It was like a sort of a satellite meeting. We had a 14-year-old that won the AI part of the competition. So never underestimate a young person.
Neil just missed the cutoff.
I'm sorry?
He just missed the cutoff.
He just missed the cutoff, okay. So amazing work. I hope we'll convince some of you to go into medicine. We so badly need people like you in the future. So we'll take a quick picture. Unfortunately, we only have 1 plaque for the 4 of you, but any day now. We need a young person for that job. You done? Okay, thank you. Okay, all right. All right, another round of applause. Thank you so much. Okay. And we have Ashu, one other winning abstract. So there were, as you may or may not know, there are 6 categories of AI use in medicine, and Ashu took one of the categories as the top winner. So Ashu? You had very small shoes to fill.
I'm all by myself, and I'm probably as old as all 4 of them combined.
Add it together.
So our work is in an esoteric part of a specific type of congenital heart defect called sinus venosus defects. And I'm Ashu Tandon. I'm one of the pediatric cardiologists at UT Southwestern in Dallas. So these are my disclosures. So the sinus venosus defect is where the back wall of the superior vena cava, or SVC, is missing, and that lets blood from the pulmonary veins go across into the SVC. So it acts kind of like an atrial septal defect, even though it's not. And so there have been recent publications showing that you can take covered stent and put it into the SVC and recreate that back wall of the SVC. The problem with this, though, is that there's broad anatomic variability in where those veins are, how they relate to the SVC, how big the hole is. And so it's not like a one-size-fits-all solution. So how do people, right now, people plan this procedure using a myriad of echo, CT, MRI, and all these kind of 2D approaches. And you can see all the complex measurements that some of the case reports did to show how they were going to approach it. And then some of my colleagues have actually used 3D printed models to plan this kind of intervention. But what we wanted to do is see if a virtual reality solution was even better to approach this. So we used CT and MRI data. We categorized where the anomalous pulmonary veins were. We segmented the data in mimics. We generated 3D masks. And then we brought them into our custom patient-specific virtual reality environment where we could interact with the data. So what we did is we created a library of stents that would represent the potential sizes of the stents that could go in. We then measured the 1D measurements, kind of replicating what the other people had done on their CT and MRI data to see what those sizes meant. We then put in stents into the SVC, making it a little larger. That's kind of how it works so that it gets anchored against the wall. And then we tried to see, okay, does this stent effectively close the hole? That's goal number one. And then allow the anomalous pulmonary venous return to go back to the left atrium, right? Because you want the blood to go back to the part of the heart where it's supposed to. And the advantage of this kind of environment is that you can be immersed inside the heart and really evaluate whether the blood flow was going to do what it was supposed to when you were done with the procedure. So here's an example of a place where there's a large anomalous pulmonary vein that gets blocked by the stent, and so you don't want that because that means blood from the lungs isn't getting back to the heart. So what we found was that we thought that based on our criteria, 11 patients would be suitable. We had 28 total patients with this anomaly. So 11 we thought would be suitable. 7 would be equivocal, where either a small vein would get blocked or you'd have to leave a small shunt. 9 patients were unsuitable for other reasons because they had some weird anatomies. And so the most important thing that we found was that the one-dimensional measurements that you did on the CTs or MRIs before you got in the VR space didn't really predict which stent would fit in the patients that had this, that we thought would have been successful. So what we found was that sinus stenosis defects have a broad range of variability. Transcatheter closure is theoretically possible in some, but not all patients. And VR provides an excellent platform for planning patient-specific interventions in complex anatomies like sinus stenosis defects, where there's a broad range of anatomic variation. And that the 1D measurements weren't always good enough, and that we should just use 3D planning for 3D structures and stop messing around with 1D or 2D planning. So thanks. And our paper's out in JACC Imaging yesterday. So
Congratulations. So
thanks.
Some of you know I'm a pediatric cardiologist, and that's phenomenal work, and it's going to make direct patient impact,
Thanks.
which is the best. Intellectually stimulating, as well as really helpful for patients and having tough lesions. So.
Yeah, and we hope that this was just the first example of using an immersive 3D environment to plan complex interventions. And actually, since we've started using the VR, our surgeons haven't actually asked for any 3D prints because we do 3D printing a lot to help the surgeons understand the anatomy, but since then we haven't had to do.
So you kind of leapfrog the 3D printing industry, and that's one of the things I loved about your abstract. So for those of you who are radiologists here, you know that it's really mainstream now in terms of applications of AI and radiology. I think cardiology is really going to, follow. Because if you think about the medical imaging that we do, and on top of that, the decisions that we have to make, sometimes even more so than the radiologists, I think it's a natural extension of AI applications.
Yep.
Yeah. Any questions from our faculty or the audience? We have time for a couple of questions. Anybody? All right. So thank you so much for your work. We'll need a faster photographer for this picture. I'm sorry.
I think sure.
All right, can you take a picture? Okay, thank you. Okay, congratulations.
Thank you.
All right, so don't know if we're going to have the Twitter feed available for comments and questions. That's one way you can, if you're shy about using, can we have the lights up a little bit so I can actually see who may be asking questions? We have mics ready. So basically, in any aspect of today's topics and comments are free game for our faculty. I can start things off. One is, I love some of the sessions this afternoon. First of all, we had the how-to session for the first time. Did people enjoy that? Just practically speaking, how you solve a problem and how you, okay, thank you. So sounds like we can keep that. That's one of the suggestions that all of you had last year was just down to earth, real time, how do we solve a problem? So we're going to add to that and perhaps a little bit more discussion time next year. Couple of things came to mind during the afternoon sessions. One was, I think when Crystal mentioned artificial sympathy, was it? Artificial empathy? Empathy, okay, or sympathy. I think I made this comment last month at a meeting, I think it was in DC, that I think sometimes we're a little bit unfair to our machine overlords. You know, we comment that they're not perfect, they can make a mistake, and yet, you know, as Allison probably has left, but she presented a paper that basically stated that in a pile of EKGs with known diagnoses, pediatric cardiologists were missing the diagnosis one out of 3 times. So if a machine intelligence had done that, we would be very unforgiving. And I think my other comment about that is, you know, doctors and people have probably artificial empathy too. We just don't want to admit it. So what do you think about just, is that something we should do, is just be a little bit more fair about the limitations of machine intelligence? I know we're a little bit biased here because we're all believers, but do you think sometimes our profession's a little bit less than perfectly fair?
Less than perfectly fair to the physician.
Do we have a microphone? Yeah.
Less than perfectly fair to the physician or to the technology?
I think sometimes we're less than perfectly fair to the technology. At least that's more often the case when I go around and talk about this. So,
I'll start with a comment about that, if that's okay. I think that it's the expectation that when you say technology, people expect perfection, and so it removes the room to get it wrong. And in part, I think that's a projection. This is the psychology in me. It's a projection of their fear of, you know, well, they already have that fear about it, and so it's a place to put these. Yeah, I told you it was wrong. I told you it was bad. I told you it was evil.
Randall, you look like you're. Oh, okay.
It's an undefined problem, and that's the main issue, right? So we have the FDA saying we're going to be approving these algorithms, and they have the de novo process, and everybody's happy with that. But at the CMIMI conference in the summer, the main person from the FDA for AI approvals was saying, hey, we'll approve it, but we have no idea about liability. That's for Congress to decide. Yeah. And that's the elephant in the room, because we can talk about whether people trust it or not, and should we be fair, but until there's some kind of framework, it's going to be the Wild West, and I don't know if Congress is ready to act on this.
And I think they're, in fairness to the FDA, I think they're very careful right now, and I'll show a graph tomorrow. Basically, I think they have a tough job right now, and they're just giving clearances as opposed to approvals mainly, right? So, and for good reasons. So I think it's an interesting juxtaposition of the progress of technology, which is kind of taken off a little faster than anyone expected, and now we're trying to do a catch-up with regulatory. And I think it's going to be an interesting year next year to see what other devices are going to be cleared and approved. So, Randall, you look like you want to make a comment.
Well, it's sort of a dichotomy. It's not a dichotomous problem. It's not machines are perfect and humans make errors. I mean, I did some diagnostic work to see if we could look at data and come up with accurate diagnoses, but there was no gold standard. Doctors, at best, get to 75, 80% accuracy with diagnosis, which is pretty bad.
Yeah.
And if I got that out of a machine algorithm, as you say, I'd go, in fact, I did. I said, this is terrible.
Yeah.
I've only got 85, 90% accuracy here. But that's a significant improvement over what we clinically all accept. So we're going to have a period of it's good enough and it's better than human, and with human maybe it's even better still, as we keep saying. But I do think the liability issue is going to be the Wild West. And it's not going to be Congress, it's going to be every Tom, Dick, and Harry lawyer. Yeah. Are there any lawyers here so I can pick on them?
Well,
and are they listening closely?
It's funny that you mentioned Congress, because there's a viral video going around. I think one of the congressmen just yesterday or the day before. Tell us about that story.
He was grilling the Google CEO. He held up an iPhone, was complaining about his granddaughter, whatever. And everybody, the younger people started laughing, and the CEO of Google had to say, Congressman, it's a different company that makes the iPhone. We don't make it ourselves.
Yeah.
It's embarrassing.
Yeah, so we have a ways to go with Congress. So I totally agree with you. Everyone's going to need to get involved, and particularly the clinicians that have a passion for this, the patients and the families. That was so obvious from this morning's session. Everyone just needs to be involved. And I think we can solve this a lot faster than sort of allocating responsibility away from you I think is not a smart thing.
I think that a clinician, at least for the next many years, is going to be involved in mediating between the AI whatever and actually applying decisions supported with AI to a patient. They're going to be the person to finally, the last common denominator before the patient. Mm-hmm. We don't get away with saying, well, the pulse oximeter broke, so I didn't know the patient desaturated, or that the EKG machine was faulty, or my stethoscope isn't working today. It's me that's going to be held responsible for what I do to the patient with all the decision support I may have. Yeah. So we're going to be the folks that have to decide if we believe it or not. And the patients are going to hold the physicians responsible. Now, all of the AI applications that are available on my phone and on the web and will tell me, and all the bots that are out there sort of supporting my decisions in my private life, really don't know how that's going to go. I mean, we have suicide prevention AI bots providing comfort for adolescents who are depressed. What happens when the adolescent jumps off the cliff and says, well, I was talking to my bot here, and who's going to get sued? Who's going to be held responsible?
And we haven't even really, other than IDX that I mentioned this morning, really have a lot of autonomous, AI diagnostics or therapeutics. And so that's a whole range of issues that we need to solve way before we, probably not too distant in the future, because these are coming. So it's going to be an interesting few years. Yeah.
If I could just add, I think it's also the permission to be vulnerable, to say we have fears, and to say there's unknowns in forums like this that give people the permission to have those conversations, as opposed to whether it's your ego or whatever it is that doesn't allow you to be able to raise your hand and say, I'm curious or I'm fearful.
Yes.
Quick thing, what do you think about the swarm approach that has been posited, where you have that collaboration, where you have AIs and humans collaborating, and it's like strange attractors, so you see the graph and they each influence each other, and then you get to a consensus, and so that distributes the decision-making and liability so that there's that actual collaboration instead of, hypothetically in reality.
Yeah, I'm a big believer in that. I think it really ought to be bottom-up rather than top-down in terms of making these major decisions. And I think machines have a role too, right? Because they're part of the equation in a way. I think that's going to be how we resolve some of these issues in the future. Any questions from the audience? Yeah, we have a few. By the way, I just want to make another comment because I jotted this down. Someone talked about Page.ai out of New York. You did, yeah. And you may or may not be aware, there's a lot of repercussions about that in the media. That's why I brought it up. Okay, you didn't specifically go into all the issues. So the basic storyline is that a couple of insiders from Mount Sinai got together and decided to leverage data and formed a company. And I think even people on the board of directors were involved. And that's when it got really, really contentious. And expecting, I don't know what they were expecting, but certainly it was mostly negative in terms of comments from doctors in the hospital, patients wrote in. And so sort of a cautionary tale here, which is, if you're thinking about leveraging data, if you have a great idea, they had a good idea from a business perspective, but it cannot be in healthcare particularly, and particularly with Crystal's comments earlier, you cannot uncouple that from the human side of all of this.
Well, it was also about who got to invest, because it's
right.
It's a privately held
Even though the hospital
company.
was part of the investment, it really didn't, I think, mitigate the huge backlash.
It was only the board members who were invited to become investors.
Yeah.
So they're going to reap the benefits.
Yeah, but I thought the hospital was going to gain potentially as an investor. Yeah, but still, they were probably not the majority shareholder, right? So I think really have to be careful if you're thinking about getting data and supplying it for a business cause. It's particularly tricky, I think, right now. So. comments from anybody else? Okay. Can we use the microphone, because even if you think you can project, it's really hard to hear in the back. Thank you. And if you could just identify who you are and
Hi, I'm
what you do.
Dr. Chidam Coyle. I'm a clinical psychologist specialized in psycho-oncology. My question is about how AI can be incorporated in end-of-life patients who prefer to stay in-house setting rather than facilities.
You ask tough questions.
I can speak from the Stanford perspective on this. So the lab of Nigam Shah, they basically developed an algorithm that could predict one-year mortality at a really high level, which obviously I imagine many of the data scientists here, they could do a very good job of predicting that. But what they did then is they coupled that into getting these patients a palliative care consult as they were admitted to the hospital. And a palliative care consult is basically someone that will, go through the options that you have for sort of end-of-life management, end-of-life care, as well as reducing pain at the end of your days. And it's a way for you to think about how you want to do your advanced directives. And so that was a way that we could utilize the machine learning to answer, or basically mine the data to generate a predictive analytic if your patient was going to die or not, but then use that to aid the patient in helping some of these end-of-life decisions. That was one model that you could go about it.
It gets tricky because there was that MIT study that can apparently accurately predict your chance of dying while you're in the ICU. So you have all these, potential issues. I think one thing I worry about that we haven't talked about today is automation bias. If you over-rely on the predictive tool, maybe you won't be using your imagination or creativity to solve a clinical problem as much. It's just human nature, right? So, it's a problem if you over-rely on a predictive tool, especially when it comes to high mortality situations or end-of-life situations. I think you almost have to pause and really think about it without the predictive tool, and then couple your thinking with the prediction and hopefully make a better decision.
Yeah, I would echo that. I think it's really important to know what decision is going to be made on the prediction that you're giving. It's one thing to predict this patient has high mortality, so get them a conversation with an end-of-life specialist. It's entirely a different thing to say this patient has really high mortality, don't try anything anymore. Those are totally two different ways. So it's the prediction and the decision for the prediction need to be coupled together to think of what the implications are going to be in the healthcare setting.
But it's a slippery slope, right? Because
Exactly.
it can eventually get to the point where you'll take someone off the respirator based on a predictive tool that's, hopefully correct, but may not be correct either. So.
I think that also goes back to your point about liability of, if I use the data versus if I did my judgment, and then who's responsible for it. But you showed that the data was more predictable than my assessments were. And so you're definitely a slippery slope in that regard.
What's been your personal experience with chatbots so far? Anybody? No one wants to volunteer?
What do you mean by personal?
Well, outside of healthcare, tech support is an area. It's interesting because we all know that they're using them, but it's being hidden because people get freaked out.
Yeah.
So then there's all these, if you go to YouTube, you can find all these sort of people trying to do their own Turing tests, basically, right?
Yep.
To unmask. And so I wonder why. Because the chatbots are actually really good. They can help you solve problems, even at Pure. We have a support bot, but it's very clearly identified. It says, hey, I'm Pure 3, I'm a bot, I'm going to help you close your case quickly. And it works like magic. It's amazing. But why does Comcast or Cox Cable or whoever, right, pretend that it's a human being? Or like that issue with Google presenting their phone assistant, right? There was a huge backlash because of that lack of ID.
Yeah. At least I think initially we like them to identify themselves, right? At least initially. Maybe after a while, when it starts working, we won't have to worry about robot versus human. And just like I said earlier today, once it starts working, no one calls it AI anymore. So
those are the sort of standards that people need to start talking about. Should there always be symmetry of identity? I mean, the bot knows I'm a human.
That's right.
I don't necessarily know the bot is a bot.
Yeah.
And I think we've passed the Turing test multiple times, or at least many humans have interacted with bots and been unaware they were bots. And I think that's obviously going to get more and more sophisticated, and I think there probably ought to be regulatory insistence on you're talking to a bot. And we need to get over the reluctance to do that as they become better. I mean, you don't want to... We've all been frustrated over the last 10 years with dealing with phone answering devices. But they're going to get much more sophisticated, and we should know who we're dealing with, and we'll like it. I mean, your folks, give me the bot, please. He's much quicker and more direct, and there's no, he's not tired or hungover or mad at his spouse.
Well, sometimes the comments from patients that I've talked to that use a bot was that they felt more liberated because they don't feel like there's judgment from a human clinician. So,
well, and that's been adolescents seeking sexual advice have felt much more, as you say, liberated, knowing they're talking to a robot, and I don't know if they know they're part of a study, but knowing they're talking to a robot instead of a parent. And that in itself is a whole sort of, oh my goodness, what does that mean? But people are not adverse when they're high quality bots dealing with them.
Christina, you look like you want to say something, no?
No, I've never, I haven't had any of my patients use bots, or else I would...
Maybe you don't know.
Which
one of us is it?
Maybe they're afraid to tell you.
Maybe I don't know, but...
Pick out the one bot here.
I mean, do you know of any adults in, like, internal medicine? Are there any bots for
Yes. There are bots in just about every category.
Maybe.
There are bots in just about every category now. And I think I was just playing with one of the psychotherapy bots just make up things. And you get a feeling that even when they don't understand what you're replying, that they're not really comprehending, right? The subtleties of language and what you're saying. And then when I started making up just silly stuff, it's like, tell me more. It's like, so we have a ways to go. But it is impressive how far they've come, though. So in the last 12 to 18 months, particularly.
Well, there's an interesting adaptation. There's a company, I don't remember the name, but it's a drug adherence bot for older adults. And what they do is it's not an app, but they use the telephone system, the plain old telephone system, wired phones, because those people tend to feel more comfortable answering the phone. And I saw some results that were pretty amazing because there was that connection that was being developed because answering the phone was something very familiar, and that's being used clinically. And then it's actually integrated with an EMR in the back end.
So that's a great example of EQ, knowing your audience and knowing how they would engage. It makes me really happy.
And let's look to the audience. Yes.
Hi, Carrie Chern with Bay City Capital. Hi, how you doing? This has been a great conference, so thank you very much to all of you. Here's a question for each of the panelists, just trying to get your perspective on what you think the next game changer needs to be in AI to get us to the next level. So for example...
Oh, you stole my question for the last day, but it's okay.
Yeah, no, oh, sorry.
It's okay.
No, just literally, for example, it could be the genomics. Maybe it's too costly right now at $1,000 for a whole genome sequence. So maybe if we get it to $10, that would be a game changer. Or, a new model for, I've heard something about, Hinton's matrix capsules. I don't know. What, in your perspective, would advance the ball, and what would it look like, and how long do you think it would take?
Oh, okay.
I know. So, there's a joke. Ask me to predict anything except the future, right?
Well,
you have to create the future, right? It's not going to just come passively. So
I'm a data geek, and my area is imaging more than anything else. And what I think is just ripe is portables like a point-of-care ultrasound. So bringing imaging to the billions of people who never had access to imaging before, but we don't have enough radiologists to look at those images, so there's going to have to be, or if you look at what NVIDIA is doing with G Healthcare and others, there's going to be embedded trained models on the modality that are going to be doing basic triage so that when the sort of technicians in rural India or China go with a point-of-care ultrasound and image a patient, there's going to be that basic triage, and only the relevant images are going to get uploaded, and who knows whether it'll be a human or not looking at them, but that all the pieces are there for that. So that's, I don't know how many years, but it's not a 50-year proposition, and in terms of impact, it's phenomenal because we're talking about billions of people.
So as an emotion geek, I would say it's in the space of mental health because it's so staggering, so global, and within mental health, the opportunity to be able to have more engaging conversation, regular dialogue, as opposed to like what Anthony was saying about the very sort of mechanical way. I think that's a ripe opportunity, and there's so much incredible work happening
Such
already.
a big mismatch in demand and supply. It's just pure mathematics and economics. Randall, what's your prediction?
You stole my prediction. I mean, I think that the development of interactive artificial intelligence with people in lots of areas, you can pick almost anything. Massive amounts of screening, pre-preparation of anesthesia care, et cetera, et cetera. A lot of that stuff could have a huge impact. But I was sort of really thinking about what's preventing the technology which we now have available from reaching the wider population. I do a mission trip to Haitians in the Dominican Republic, where I see in a week about 1,000 patients. I could easily be replaced by a bot for the sort of level of medicine I'm practicing, but since my time is free, they can afford me.
You're way cheaper than a bot.
and replacing me with technology in that setting certainly is technologically possible now, but isn't going to happen. So I was trying to answer that question with what are the barriers to really widespread dissemination of things we have. I mean, the concept between IoT, et cetera, it still hasn't taken off as fast as I would expect.
So something that I would really like to see that I think is reachable is EMRs, and we've all talked about it. It is just so bulky, and it destroys my soul sometimes to use it when you cannot get the orders you want, when you have to push a billion things, when it's difficult to communicate, when there's 100 billion notes to read. And so I think that there's a lot of work that doesn't necessarily require very difficult AI to streamline a lot of this. And a lot of people have mentioned, like Epic was made for billers and not physicians. But I think you can actually probably work in even the Epic framework to improve it, to make it easier for physicians to use so that they are not spending all the extra time doing things that won't necessarily help patient care. And also in terms of notes. So I still have clinic notes to do that are not done yet. And I know that for a lot of people who have a lot of patients, a lot of times having a lot of notes and work to do on the EMR is very difficult. And I know that people are working on this, but if they can automate it, right, and go from like voice to text, and perhaps pre-populate a note or something, that would just make things a lot smoother. And not only would it possibly do that, but if you can take that unstructured data and get information out of it, then it could even perhaps have suggestions and provide back-end data for the medical database as well.
Great.
I think actually the biggest gains to have from the healthcare setting are actually going to come from nudging of patients to get them to do small actions that actually improve their health. So I think someone spoke earlier about how in this country we're only doing sick care, and I completely agree with that. I think we really do need to get into more healthcare focus, and I think actually as the younger generation's a lot more open with sharing their data, and we have insurance companies that are doing things like, oh, if you give us access to all your data, give us your credit card information and things like that, we'll give you better discounts. And everyone's trying to save money these days. And so I can imagine a system where actually your insurance company becomes your biggest advocate. So they want to keep you out of the hospital. They want to, cut down your cost. And so if they have access to your like Facebook and they just saw that you made a purchase of like a burger, the next ad you're going to get, or next friend post you're going to get, it's going to be like, oh, I switched to salad, I'm vegan now. Because they're trying to, nudge you into behaviors that just make you cost less. The thing is, those same behaviors that make you costless make you healthier. And so I actually think the biggest gains are going to be more of opening up the cost data to the people that actually have the cost burden to get them to influence your decisions. I think really the nudging and embedded technology space is where the future is going to be.
And then I have one more thing that I think would also be really cool. So sometimes when you change a patient's medications or something, you have this follow-up period. But then there's all this time between when you change things and when they follow up, or all this time in between when they don't see you where you don't have any data points. But patients are taking their blood pressures at home possibly, and they have this information that they're just not sharing with you. So I know that, I think our hospital is trying to do it, and they have a few test people in the back end, but the blood pressures that they get at home and the readings, that they have an app on their phone and it directly downloads into our EMR. But that could possibly bridge this gap between when something goes wrong and the time they actually see a physician, because you don't always have a healthcare provider there.
Yeah, actually going to be, my intro remarks on Saturday morning is actually going to be about predictions in terms of the near future and the far future. But I think one area that we don't talk about enough is how we educate our physicians and how draconian it is. And I teach a board review course for pediatric cardiologists trying to pass their boards. And it's just a painful reminder. I just did one in August. The angst that particularly young people going through it for the first time. Is it really, really a good thing to do for our about to be burned out young physicians going through this process? It just kind of encourages the burnout, right? The stress. So my feeling was in the future, hopefully one of you will take up this idea of massively, radically changing how we look at medical education. It could be, for instance, a question on your app every day, and if you don't get it right, it comes right back at some point later, and perhaps embedding educational nuggets into the EMR, which is, in my mind, the best time to learn. If you have a patient that has a syndrome or diagnosis that you don't remember, wouldn't it be nice just to do a little CME activity right there to help your patient and help your education, right? Something fairly basic, but we have the technology to do it. The sad part to me is we still insist on giving someone a board exam every 10 years and hope they pass, so that they to us, means that they're competent enough to take care of patients, which is, as you know, really far from the truth. So I'm hoping that we'll make some inroads, and especially with AR, VR now, make some really serious inroads into medical education. All right? 10 minutes, okay. That was very subtle. Thanks, Megan. Okay. Okay, we can take a couple of more questions. Yeah.
Right here. Hi. My name's Elaine Moe, and I think I'm thinking of things more on like the business side. So today's conversation was a lot from the perspectives of clinic practitioners and data scientists.
Yeah.
But I haven't heard much about how you collaborate on the private sector. So there's a ton of startups out there, really smart software engineers that are solving the problems right now, have technology developed to help your day-to-day operations, go faster. So how are you looking to partner or collaborate with these startups?
Great question. We actually had a workshop yesterday, I don't know if you were here yesterday, entirely focused on the entrepreneurial side of AI in medicine. Sorry you missed that. It was pretty popular, so we're going to repeat it, obviously, and maybe have an extended version. Arlen Myers, who's here somewhere, I think, and Steve Ardieri led that. I think the pitch event tonight, there'll be a lot of real-life lessons learned, hopefully. If you're thinking about just sort of basic lessons learned in that sector and how do you avoid pitfalls, is that what you're sort of thinking?
No. So for example, there was a speaker that was talking about how they have the whole data science pretty much section was how they're pretty much, almost reinventing the wheel, and they're trying out to find some sort of solutions. But why do that internally when you could partner with a startup?
Yeah, so being more efficient in terms of resources to have a startup that actually will have legs in terms of going through for funding and everything else. And do you guys want to take a crack at that?
There's also forums now. I just met a gentleman with Scale LA, forums that are specific to healthcare entrepreneurship. And so I think those are great platforms for that.
But one thing I see is that there's a lot of people out there with great ideas, but they have no idea how healthcare works. So to me, just from the infrastructure side, but interacting with a lot of people who are sort of in that space of good ideas, they have to understand that unless you integrate into existing workflows, you're going to fail. That you have to understand how physicians work, and that having a great widget is absolutely not enough, because people are overworked already, and you can't tell them, now you have to go to this other screen and launch this other app because it's going to be awesome. They're going to kill you. So it's that understanding that there's got to be interaction with the old school PACs, in my side of the world and things like that, that has to be part of the startup mentality.
It's much more than having a physician on the advisory board, which is what you always see. But when I asked, when was the last time you talked to your physician on the advisory board? It'd be like 3 weeks ago. So it really has to be in step, I think, with your product, your MVP development, that you work hand in, side by side with a clinician.
Yeah, so, being at a big lab in Silicon Valley, we have no shortage of startup people coming to us, knocking our door every day, being like, oh, we have this great idea, and we'd love to try it out on real patient data and things like that. And I would actually say the vast majority of ideas that cross my desk are flat out terrible. And the other thing is, I think startup mentality is so much about disruption. And like what's being said here, disruption of workflow will never fly in the hospital. The systems, yes, they're not super efficient, but they have been built over decades in these hospitals to get the work done that they need to get done. If you're going to do something like adding a new widget or having someone open up something that's not epic to get their work done, it's just not going to fly. The amount of burden to add a new system to the workflow is really something that just doesn't work. And so the ideas that have been mentioned with the UX and the empathy and things like that really do need to design your product for the people that are going to use it. I think products that are designed for the end patient in mind, those can sort of be whatever system that the startup wants. But if you're going to actually design for a B2B sale at the hospital, you really have to have a very clear understanding of the workflow, the value add, how much revenue you're going to save, or how much the revenue you're going to generate for the hospital, how much you're going to save, and things like that. Because at the end of the day, hospitals are still businesses. They do need to make a revenue.
Sort of business 101 for any advanced technology, that you go to the problem first. And we're always, as human beings, so tempted to go to the solution first and then try to sell it. And it's just more efficient and less problematic when you start from the problem side first. Yeah, I totally agree that you get a lot of presentations on services and products that just did not involve the clinicians nor the patients enough, and people are just in this rush to do something and come up with a service or a product that inevitably will fail. And I think I'm seeing a lot. We talked about AI in medicine around the world right now, earlier this morning. I see a lot of that in China right now. They're just investing into, because they're afraid to miss or benefit from the bubble. And a few are making it, with serious funding, but not so good services or products. So I think it's good to just not waste resources so early. What I'm really afraid is we'll artificially create another winter, and we'll run out of resources at some point when the really hard artificial intelligence projects with good ideas behind them are going to come, and we're going to be running out of resources or patience.
That being said, I do think there is a lot of role for institutions and hospitals and academic medical centers to create some version of an incubator internally for a group to have access to the patient data and things. Because if you are an AI startup, most likely you have commercially available data sets which aren't truly the data sets that the hospitals themselves are working with when they're trying to provide care. So I do think there is definitely room for institutions to develop their own internal incubators to allow companies sort of to apply to work within their setting.
And we're also starting to see true partnerships between large hospitals and genomic companies. So hopefully AI can look at that model and really try to maximize the chance of success.
Just an example, we're working with the University of Wisconsin Medical School. They partner with their School of Engineering. They have 200 data scientists, 200 working with the chief medical informatics officer, and they're standing up a infrastructure as a service for research. So that kind of model, right, where they're doing their own incubation and they can decide if they want to work with people or not, is probably the only way to go, because they're also training physicians and engineers and data scientists for the future. So that seems to be, just from what I've seen, that's among the best.
But the point's well taken that the data science group really needs a more robust business entrepreneurial background. And oftentimes they fail, not because the idea wasn't good, but they just didn't have the execution side down. And it's really a crying shame when you see that. So with that, we're going to end our open forum. We're going to do a quick transition, and we're going to go into the exciting pitch event.